Usually, when we think about getting a medical diagnosis, there is this expectation of absolute precision, you know?
Right, yeah, like it's black and white.
Exactly. You fall, you break your arm, they take an x-ray, and boom, there's a jagged white line on the screen.
Very clear.
Yeah, the doctor points to it, and you know exactly what is wrong. It's a binary reality. Broken or not broken, I mean, it's a very clean, very comforting way to view medicine.
Oh, absolutely. We naturally gravitate toward that kind of certainty. Humans want things to be visible, classifiable, and, easily fixed.
But the moment you step through the double doors of an intensive care unit, that comforting x-ray machine metaphor just completely shatters.
It really does. It goes right out the window.
Right, like when you enter the realm of neurocritical care, systemic organ failure, profound physiological trauma, you're looking at a diagnostic landscape that is just incredibly murky.
Really?
It's no longer about finding the one broken thing. It's about managing an entire biological ecosystem that is collapsing all at once. So, okay, let's unpack this.
Let's do it.
The stack of sources we are looking at today for this deep dive is a comprehensive, highly technical board examination prep document designed specifically for critical care physicians.
The real heavy hitters.
Yeah, exactly. We're talking about the final hurdle, right? The highest tier of medical training for the people who manage the absolute sickest patients in the hospital.
This is essentially the blueprint for the doctors you pray are standing at the foot of your bed when every single system in your body has gone completely off the rails.
Well said. And our mission today isn't to, quiz you on flashcards.
No flashcards here.
Right. It is to give you a front row seat to the intense, highly algorithmic, and unimaginably high-stakes frameworks these doctors use to snatch patients back from the absolute brink of death.
It's intense stuff.
It is. You're going to see how the sheer terrifying chaos of a crashing human body can actually be managed through strict mathematical formulas, aggressive pattern recognition, and just an incredibly deep understanding of cellular biology.
What's fascinating here is how the ICU brings order to biological anarchy.
Oh, I like that phrase. Biological anarchy.
Yeah, because it's an environment where you don't just react to a symptom. You have to anticipate the downstream cascade of every single intervention. Like a medication you give to fix the lungs
Right.
might inadvertently destroy the kidneys a day later.
Wow. Yeah, that's the tightrope. And we are going to take you on a journey through that exact chaos today. We're starting at the top, inside the rigid vault of the skull, to see what happens when the brain is under extreme pressure.
Yeah, start with the control center.
Exactly. Then we're going to explore systemic organ meltdowns in the abdomen, decode some bizarre microscopic traffic jams in your bloodstream.
Those are wild.
So wild. We'll navigate the terrifying world of toxic pharmacology, and finally, we'll look at the profound ethical dilemmas that really only exist in the ICU.
It's a lot of ground to cover.
It is. But to really grasp critical care, you have to start at the control center. So let's look at the brain facing a catastrophic insult.
So to understand the brain in crisis,
Yeah.
you really have to understand the physical architecture it's trapped inside.
The skull.
Right, the skull. The entire field of neurocritical care is governed by something called the Monro-Kelly Doctrine.
Okay.
It is the absolute non-negotiable foundational principle of intracranial pressure, or ICP.
So I was reading through the section on the Monro-Kelly Doctrine, and I kept picturing the human skull as this exclusive VIP nightclub.
Oh, I like that. A nightclub.
Yeah, but this particular nightclub has a terrifyingly strict fire code because it's built out of thick, unyielding bone. It physically cannot expand, not even a millimeter.
No, the cranial vault is a completely fixed space. That's the core of the doctrine.
Right, and inside this rigid, bony nightclub, you have a fixed volume of three very specific things. First, you have the brain parenchyma itself, the actual brain tissue.
The VIPs.
Exactly, the VIPs. Second, you have the cerebrospinal fluid, or CSF, which kind of cushions everything. Let's call them the wait staff.
Okay, wait staff, sure.
And finally, you have the blood, which is constantly flowing in and out to deliver oxygen. That's your general admission crowd.
Perfect analogy. And as long as the total volume of those three components remains perfectly constant, you have a balanced, functional ecosystem.
But the doctrine points out a terrifying mathematical reality. If an uninvited guest forces their way into the club,
Like a mass.
yeah, let's say a massive, rapidly growing tumor, or, a pool of blood from a ruptured aneurysm, or just severe brain swelling from a trauma.
Something has to give.
Right. Someone else has to get kicked out, because if they don't, the pressure builds until the structural walls fail. And in the brain, the walls don't burst outward.
I can't.
The brain is forced downward toward the only exit available, which is the opening at the base of the skull where the spinal cord connects.
Which results in a fatal brain herniation.
And that's immediate lights out, right?
Basically, yes. We look for signs of central or uncal herniation, where the temporal lobe or the brainstem itself gets physically crushed against the base of the skull.
Oh, that sounds awful.
It is. Because the brainstem is the primitive control center for your automatic breathing and your heart rate, compressing it is an immediately fatal event.
Wow.
So the Monro-Kelly doctrine dictates this zero-sum game. An increase in the volume of any one component must be offset by a reciprocal decrease in the others, or the intracranial pressure skyrockets and the patient dies.
So if you're the doctor standing at the bedside, right, and the pressure monitor inside the patient's skull is just screaming that the pressure is rising, how do you fight back against physics?
You fight back with math.
Math, okay.
Yeah, the math of survival in this scenario centers on a specific formula. Cerebral perfusion pressure equals arterial pressure minus intracranial pressure, or CPP equals MAP minus ICP.
Okay, I want to make sure I really understand this because the sources stress this heavily. Cerebral perfusion pressure, the CPP, that's the actual net force of blood making it into the brain tissue to deliver oxygen, right?
Yes. Think of it like trying to pump water from a hose into a sealed, pressurized tank.
Okay, hose in a tank.
Right. The mean arterial pressure, the MAP, is the force of the water coming out of the hose. That's your systemic blood pressure generated by your heart.
Got it.
The intracranial pressure, the ICP, is the pressure already inside the tank pushing back against the water.
Ah, I see.
So if the pressure inside the skull is pushing outward with a force of, say, 30 millimeters of mercury, and your heart is only pumping blood inward with a force of 30.
It's a stalemate.
Exactly. It's a stalemate. No blood flows in.
So the brain starves of oxygen even if the heart is beating perfectly fine.
Precisely. This is why maintaining a robust, elevated systemic blood pressure is the absolute holy grail of neuroresuscitation.
Wait, really? You want the blood pressure to be high?
You absolutely do. You literally have to force the heart to pump harder than the swollen brain is pushing back.
That is wild. But pushing blood in doesn't solve the overcrowding in the nightclub, right? The sources outline a strict tiered management algorithm to actively bring the intracranial pressure down.
Yes, the tears.
And what really struck me about tier 1 is how physical and chemical it is, rather than relying on like complex machinery.
Well, tier 1 interventions are elegant in their simplicity. We start by manipulating gravity.
Just gravity.
Yeah. You elevate the head of the patient's bed to exactly 30 degrees. This optimizes venous drainage through the jugular veins. You're literally just giving the blood a downhill slope to leave the skull.
Which reduces the volume of that one component the general admission crowd is leaving the club.
Exactly. We also ensure deep sedation and analgesia because pain, agitation, or even just coughing can dramatically spike intrathoracic pressure.
And that backs things up.
Right. It backs up the blood trying to drain from the head, which raises the ICP.
That makes total sense. And then comes the chemistry aspect, which the text calls hyperosmolar therapy.
This is where we manipulate the fluid dynamics. We administer incredibly concentrated saltwater hypertonic saline, or a sugar alcohol called mannitol, directly into the veins.
Right into the IV.
Yep. By injecting these extremely dense solutes into the systemic bloodstream, we alter the osmotic gradient across the blood-brain barrier.
But you're essentially turning the blood into a sponge.
That is a great way to visualize it. The highly concentrated blood actively draws the excess swelling fluid out of the waterlogged brain tissue and into the intravascular space.
Where it can be carried away.
Exactly. Carried away and eventually peed out by the kidneys. It shrinks the brain tissue slightly to buy us room in the vault.
But let's say the swelling is just so aggressive that gravity and salt water aren't working. The pressure monitor is still climbing.
Then we have to escalate.
Right. The sources say you move to tier 2, which relies heavily on something called transient hyperventilation. The respiratory therapist changes the ventilator settings to make the patient breathe much faster and deeper.
Right, intentionally driving their carbon dioxide levels, their PaCO2, down to between 30 and 35 millimeters of mercury.
Now, I have to push back on this because reading the mechanism here genuinely confused me.
Okay, walk me through your thought process.
So the text explains that lowering the carbon dioxide causes the blood vessels in the brain to shrink, right? Vasoconstriction.
Yes.
And I get that shrinking the vessels means there's less blood volume inside the skull, which lowers the pressure.
Correct.
But if you are intentionally shrinking the blood vessels, aren't you choking off the brain's oxygen supply? Like, why on earth would you intentionally induce a stroke to save a brain?
It is a brilliant question, and you've put your finger right on the most dangerous edge of neurocritical care. You are absolutely correct.
I am.
Yes. Hypocapnia, which is the medical term for low carbon dioxide in the blood,
Mm-hmm.
induces very potent, very rapid cerebral vasoconstriction. The vessels clamp down hard,
Okay.
and because there's less blood volume in the rigid cranial vault, the intracranial pressure plummets almost instantly. It's a highly effective rescue maneuver.
But the cost.
The cost is extreme risk. As you pointed out, excessive vasoconstriction absolutely can and will induce profound cerebral ischemia.
Mm.
You're trading pressure for blood flow. This is why the guidelines stress that hyperventilation must only be used judiciously, transiently, and as a bridge to a more definitive therapy.
So you can't just leave them like that.
No, absolutely not. You cannot leave a patient hyperventilating for days, or you will cause massive ischemic brain damage. You use it for minutes or maybe hours to prevent herniation while you prepare for Tier 3.
And Tier 3 is where the options get truly desperate.
Desperation therapies, that's what they are. If the pressure's still uncontrolled, we move to a barbiturate coma.
Coma.
Yes, we infuse massive doses of drugs like pentobarbital. The goal is to maximally suppress the brain's electrical and metabolic activity. We are basically shutting down the factory.
To save energy.
Exactly. By reducing the brain's metabolic demand to near zero, we drastically reduce its intrinsic need for blood flow, which in turn drops the pressure.
And if the chemical shutdown fails, it becomes a structural problem again,
The decompressive craniectomy.
which is taking off the skull.
Literally. The neurosurgeons take the patient to the operating room and physically remove a massive section of the skull bone. You take the roof off the nightclub.
Oh my God.
The swollen brain now has room to expand outward beneath the scalp, preventing it from herniating downward into the brainstem.
It is staggering to think about the sheer physical management of the brain, but the sources also dive deep into a purely electrical emergency. Status epilepticus.
Ah, yes. Status epilepticus is one of the most profound neurological emergencies we face.
That's essentially a seizure that won't stop, right?
Yes, it's defined as a continuous unrelenting seizure or a series of seizures without recovery in between. The layman's perspective is often focused on the physical convulsions, the shaking.
Right, that's what we see in the movies.
But for the intensive care physician, the physical shaking is really a secondary concern. The real crisis is what is happening at the microscopic cellular level.
The document uses this phrase, irreversible excitotoxic neuronal injury. Can you break down what excitotoxicity actually means in this context?
Imagine a car engine. Normally it revs up, does some work, and then idles.
Okay.
In status epilepticus, the neurons, the brain cells, are redlining at maximum capacity, firing electrical signals violently and continuously without a single pause.
So they're just flooring the gas pedal.
Exactly. And this massive electrical storm forces calcium channels on the cell membranes to stay permanently open.
And too much calcium inside a cell is toxic.
It is lethal. Massive calcium influx triggers a cascade of destructive enzymes inside the neuron that literally tear the cell apart from the inside out.
Wow.
The neurons burn themselves out and die. This excitotoxicity begins to cause permanent, irreversible brain damage within just minutes.
Which totally explains why the treatment guidelines are phased so aggressively based on the clock. I mean, time is literally brain.
Every single minute of seizure activity increases the risk of permanent cognitive deficits or death. The algorithm is ruthless.
So phase 1 is the first 5 to 20 minutes. The frontline defense is rapid-acting benzodiazepines.
The circuit breakers.
Right. The guidelines specifically highlight intravenous lorazepam. Or, if you can't get an IV in someone who is violently seizing, intramuscular midazolam.
Benzodiazepines bind to receptors in the brain to enhance the activity of GABA.
GABA.
GABA is the brain's primary inhibitory neurotransmitter. It's the chemical equivalent of slamming on the brakes. We flood the system with inhibitory signals to force the electrical storm to stop.
But let's say the brakes fail. You give the lorazepam, and the patient is still seizing. You enter phase 2.
Phase 2 brings in the non-benzodiazepine anti-epileptic drugs. The guidelines list agents like levetiracetam, fosphenytoin, or valproate.
Do they work differently than the benzos?
They do. Instead of enhancing the brakes, they try to stabilize the electrical membranes of the neurons themselves, often by blocking sodium channels to prevent the cells from firing in the first place.
Got it.
The data shows they have comparable efficacy to each other, so the choice often depends on patient-specific factors.
But if you administer the heavy artillery and you watch the clock and they are still seizing, the sources say you have now entered the territory of refractory status epilepticus.
The worst-case scenario.
And this mandates phase 3.
Phase 3 is where critical care takes over completely. The brain has refused to stop destroying itself, so we have to take the brain offline.
The text mentions intubation and continuous anesthetic infusions.
Yes. We place a breathing tube and put the patient on a mechanical ventilator because the drugs we are about to use will stop their breathing.
Wow.
We then initiate continuous, massive intravenous infusions of potent anesthetics like propofol or pentobarbital. And we aren't just giving enough to make them sleep.
You're going deeper.
Much deeper. We are actively titrating these drugs while watching the patient's brainwaves on a continuous EEG monitor. Our target is a very specific state called electroencephalographic burst suppression.
Burst suppression, meaning you give them enough anesthesia until the continuous jagged electrical storm on the monitor flatlines, leaving only tiny, occasional little bursts of background activity.
Yes. We chemically induce a state of near-zero electrical activity. We forcefully halt the excitotoxic destruction by plunging the brain into a profound artificial silence.
It's essentially pulling the plug on the central nervous system to force a hard reboot.
That's exactly what it is, a hard reboot.
Incredible. Before we move on from neurocritical care, there was a fascinating pearl in the sources regarding stroke management that seems to fundamentally change how we think about time and treatment.
You're referring to the shifting standard of care for acute ischemic strokes caused by a blood clot in the brain.
Right.
For decades, the gold standard therapy was a thrombolytic drug, a clot buster called Alteplase.
But the document highlights recent landmark trials, specifically mentioning the OPTION and TRACE-5 trials that are pushing a different drug to the forefront.
Tenecteplase, yeah.
Why the sudden shift? What makes tenecteplase so much better?
It comes down to pharmacology and logistics. Tenecteplase is a modified version of Alteplase, engineered to be far more fibrin-specific.
Meaning it targets the clot better.
Exactly. It targets the structural framework of the blood clot much more aggressively, while theoretically causing less systemic bleeding elsewhere in the body. But the real game changer is how it's administered.
Logistically.
Yes, logistically. Alteplase requires a complicated dosing regimen. An initial bolus dose, followed by an hour-long continuous intravenous infusion.
That sounds clunky in an emergency.
It is. If that patient needs to be rushed to the CT scanner or transferred to another hospital, dragging a running infusion pump along is precarious. Tenecteplase, however, can be administered as a single, rapid intravenous push over 5 seconds.
You just push it and you're done.
Just push and you're done.
Yeah.
And what the OPTION and TRACE-5 trials demonstrated is that this single push drug is highly safe and effective, even for acute non-large vessel occlusions, and crucially for basilar artery occlusions up to 24 hours after symptom onset.
24 hours, that's a huge window.
It's massive. In a disease where every single minute millions of neurons are dying, a drug that is faster to give, easier to manage, and highly effective represents a massive leap forward in care.
Okay, we are going to pivot our focus now. We've spent a lot of time looking at the failing compensatory mechanisms and the physics of the brain.
Let's move down the body.
Yes, now we're going to explore the systemic organ meltdowns that happen when the chemical factories of the body begin to collapse.
The transition from the brain to the abdomen is a transition from electrical and physical pressure problems to profound biochemical disasters.
And no organ represents a more complex biochemical factory than the liver.
The liver is incredible.
The sources outline the terrifying reality of acute liver failure, or ALF. They define it by 3 distinct criteria occurring simultaneously, right?
Right.
First, severe hepatocellular injury. The actual cells of the liver are dying in droves. Second, a profound coagulopathy, meaning the blood loses its ability to clot. They note this as an INR greater than 1.5. And third, the onset of hepatic encephalopathy.
That third point, the encephalopathy, is the linchpin of the diagnosis.
What is that?
Well, the liver's primary job is to act as a filtration plant. It constantly scrubs the blood of metabolic waste products, the most notable being ammonia, which is a byproduct of protein breakdown in your gut.
Okay.
When the liver cells die rapidly, that filtration stops. The ammonia levels in the blood skyrocket.
And the ammonia travels to the brain, I'm guessing.
Yes, it easily crosses the blood-brain barrier. Once inside the brain, it alters neurotransmitter function and causes the brain cells to physically swell.
Oh,
The
wow.
patient becomes confused, lethargic, entirely uncoordinated, and eventually slips into a deep coma. That is hepatic encephalopathy.
And the defining, terrifying feature of acute liver failure is that this entire cascade happens in a patient who has absolutely no prior history of chronic liver disease.
None. No cirrhosis, nothing. A healthy person suddenly goes into complete multi-system collapse over a matter of days.
When a patient crashes that hard and fast, the ICU doctor has to figure out incredibly quickly if the liver can regenerate or if the patient is going to die without an immediate transplant.
The stakes couldn't be higher.
Right. And to make that calculation, the sources detail the King's College Hospital criteria.
The King's College criteria is a predictive model. It's the gold standard algorithm used globally to stratify which patients need to be immediately lifted for an emergency liver transplant.
And what is most fascinating about the criteria to me is how it completely forks based on a single piece of information: what caused the failure.
Yes.
The algorithm splits into two entirely different pathways: acetaminophen toxicity versus literally all non-acetaminophen causes.
It does.
Acetaminophen, Tylenol. I mean, I was stunned reading this. Why does a ubiquitous, over-the-counter painkiller that millions of people take every day get its own exclusive category and its own unique criteria for a life or death transplant?
It's a great question. It requires its own pathway because the mechanism of destruction that acetaminophen uses is totally unique, and it dictates a completely different physiological trajectory.
How so?
To understand this, we have to look at how acetaminophen kills a liver cell. In a massive overdose, the drug causes direct, overwhelming failure of the mitochondria, the powerhouses of the cells.
It shuts down their energy production.
Completely. It causes profound, widespread cellular necrosis. The cells just die and burst open.
Okay, that sounds bad.
It is. And here's the key consequence.
Mm-hmm.
Because the mitochondria fail, the liver cells cannot process oxygen for energy anymore. They're forced to switch to anaerobic metabolism as a last gasp just to stay alive.
And the byproduct of anaerobic metabolism?
The byproduct of massive organ-wide anaerobic metabolism is the production of astronomical amounts of lactic acid.
And the acid dumps into the bloodstream.
Yes. It creates a profound arterial acidemia. The blood turns dangerously acidic.
Wow.
And this is why, if you look at the King's College criteria for acetaminophen toxicity, an arterial blood pH of less than 7.3 after fluid resuscitation is considered an independent, standalone indicator of a desperately poor prognosis.
So just that one single number, a pH below 7.3, tells the physician that the mitochondrial collapse is so massive, the necrosis so widespread, that the patient will likely die without a new liver.
Exactly.
Just that one number. But the algorithm has a second step for acetaminophen, right? What if their pH is okay? What if they haven't become massively acidotic and the pH is greater than 7.3?
Then, the criteria demand proof of multi-system failure to justify a transplant. If the pH is greater than 7.3, the patient must exhibit all three of the following simultaneously.
All three?
All three. An INR greater than 6.5, a serum creatinine greater than 3.4 milligrams per deciliter, and severe grade 3 or 4V hepatic encephalopathy.
Let's translate those numbers, because as a layman reading the sources, those thresholds felt a little arbitrary until I looked at what they actually represented.
Write them down.
Okay, an INR greater than 6.5 means their blood is so thin they are essentially incapable of forming a clot. A creatinine greater than 3.4 means the toxic load has become so great that their kidneys have now failed as well. And grade 3rd or 4th encephalopathy means the brain is so swollen with ammonia that they are unarousable or comatose.
Exactly. If the acidemia isn't there to prove massive necrosis, the criteria demand evidence that the liver has completely stopped producing clotting factors, the kidneys are shutting down in sympathy, and the brain is heavily compromised.
It's a very strict bar to clear.
It has to be, because a transplant itself is a massive trauma. You don't put someone through that unless there is absolutely no other option.
Now let's look at a different chemical factory in the abdomen that can go rogue: the pancreas. Severe acute pancreatitis.
Another terrible disease.
The sources make a point to highlight how a localized problem in the pancreas can rapidly evolve into systemic inflammatory response syndrome, or SIRS, and even destroy the lungs, causing ARDS.
Pancreatitis is uniquely terrifying. Think about what the pancreas does. It produces incredibly potent digestive enzymes designed to break down the proteins and fats in the food you eat. Normally, these enzymes are inactive until they are safely delivered into the intestines. But in acute pancreatitis, due to, say, a gallstone blockage or alcohol toxicity, these enzymes activate prematurely while they are still inside the pancreas.
So the organ starts digesting itself.
It literally auto-digests,
Right.
and as the pancreatic tissue dies, it triggers a monstrous whole-body inflammatory immune response.
It affects the whole body.
Yes, this inflammation damages blood vessels everywhere, causing them to become leaky. The fluid from your bloodstream weeps out into your tissues, including your lungs, causing acute respiratory distress syndrome.
To predict how bad a case of pancreatitis is going to be, the sources detail something called Ranson's criteria. And the structure of Ranson's criteria really caught my attention.
How so?
Well, it isn't a single test. You take one set of specific measurements the moment the patient is admitted to the hospital, and then you have to take a completely different set of measurements exactly 48 hours later. I was trying to conceptualize why you would do it this way. And it feels a lot like assessing the damage of a major hurricane.
I think that is a very apt analogy. Explain how you see it.
Well, when the patient first arrives, the admission criteria look at initial demographic and lab values. It looks at age over 55, a white blood cell count over 16,000, high liver enzymes like AST and LDH, and a blood glucose over 200.
The initial impact.
Right. It's like measuring the barometric pressure and the wind speed right when the storm makes landfall. You look at the readings and say, okay, this is a category 4, this is going to be bad.
Exactly.
But I have a question about those admission labs. I understand why white blood cells rise. There is inflammation. But why is a dying pancreas making the blood sugar spike over 200?
You're hitting on a crucial mechanism there. The pancreas isn't just one type of tissue. The part destroying itself is the exocrine tissue, which makes the digestive enzymes.
Okay.
But scattered throughout the pancreas are the islets of Langerhans, the endocrine cells that produce insulin.
Oh,
When the pancreas is inflamed and digesting itself, those insulin-producing cells are damaged, and insulin secretion plummets.
so the blood sugar goes up.
Yes, and concurrently, the massive physical stress of the illness triggers the release of stress hormones like cortisol and epinephrine, which naturally drive your blood sugar up even further. So you have a massive stress-induced sugar dump into the blood and the damaged pancreas that cannot produce the insulin needed to process it.
That makes perfect sense. So that is the wind speed at landfall. But my hurricane analogy continues because you can't assess the true devastation of a hurricane while the wind is still blowing.
No, you have to wait.
Right. You have to wait a couple of days for the storm surge to recede to see if the foundation of the house washed away. And that is exactly what the 48-hour Ranson's criteria are doing.
Precisely. The 48-hour criteria measure the systemic fallout, the collateral damage of that massive inflammatory storm. We look for a drop in hematocrit greater than 10%, which tells us there is active internal bleeding or massive fluid shifts diluting the blood. We look at the arterial oxygen, the PaO2 dropping below 60, proving that the inflammatory fluid has leaked into the lungs and is impairing oxygen exchange. We look for a rising BUN, blood urea nitrogen, showing the kidneys are taking a hit.
And the craziest criteria on the 48-hour list to me is massive fluid sequestration greater than 6 liters.
Yes, 6 liters. Because of that massive whole-body capillary leak we discussed, the patient's blood vessels become porous. They can literally leak 6 liters of their own intravascular fluid out of their veins and into the retroperitoneal space, the back of the abdominal cavity.
That's insane.
The patient goes into profound shock simply because their blood vessels are empty, even though the fluid is still inside their body.
And if the total score across both the admission and the 48-hour mark is 3 or greater, that signifies severe pancreatitis, mandating ICU admission and aggressive fluid resuscitation to refill those leaky vessels.
Right.
Now, there was a very specific, almost warning-like pearl in the sources regarding the treatment of this dead pancreatic tissue.
Yes, a critical what not to do that is heavily tested and relevant at the bedside.
Unpack that for us.
When the pancreas dies, that dead tissue is called necrosis. It is incredibly tempting for a doctor to look at a massive pocket of dead tissue inside the body and want to blast the patient with intravenous antibiotics to prevent an infection.
I mean, that sounds logical. Dead tissue, infection, antibiotics.
It does, but the guidelines explicitly state that the administration of prophylactic antibiotics for severe acute pancreatitis, specifically when the necrosis is sterile, is not supported by current evidence.
So you do not give antibiotics just because the organ is dead.
Correct. You only initiate antibiotics if you have definitive clinical or imaging proof that gut bacteria have actually invaded and infected that dead tissue.
Wow.
Giving prophylactic antibiotics doesn't improve survival. It just breeds highly resistant superbugs in an already critically ill patient.
Okay, let's talk about the physical consequences of all that fluid leaking into the abdomen that you mentioned with the 6 liters of sequestration. This leads us directly into our next abdominal emergency, abdominal compartment syndrome, or ACS.
So we talked about pressure in the skull with the brain. ECS is the exact same mechanical principle, but localized to the abdomen.
Just a different compartment.
Exactly. It's defined as a sustained elevation of intra-abdominal hypertension, dangerously high pressure inside the belly, that directly leads to new onset organ dysfunction.
The sources provided a really intense illustrative context for this, specifically looking at severe burn patients.
Burn critical care is perhaps the most visceral example of this pathophysiology.
How so?
When a patient suffers severe, full-thickness burns covering more than 40% of their total body surface area, they experience a catastrophic systemic capillary leak. The massive thermal injury releases mediators that cause blood vessels all over the body to dilate and become highly permeable.
The fluid just pours out of the vessels.
The vascular system completely loses its integrity. To keep the patient alive, to keep their heart pumping and blood reaching their brain, we have to administer massive, almost unbelievable volumes of crystalloid fluids into their veins.
The document mentions resuscitation volumes greater than 250 milliliters per kilogram in the first 24 hours. Let's do the math on that. If I weigh 80 kilograms, that is 20,000 milliliters.
20 liters.
That is 20 liters of intravenous fluid in one day.
It is an astronomical volume. And remember, their capillaries are still leaking, so that 20 liters of fluid doesn't stay in the blood vessels.
Where does it go?
It weeps out into the tissues, it weeps into the bowel wall, causing the intestines to swell massively, and it pools freely in the abdominal cavity. The abdomen swells outward until the skin, the fascia, and the abdominal muscles simply cannot stretch another millimeter.
The pressure builds.
Intra-abdominal hypertension. And the downstream consequences are mechanical and lethal. As that pressure rises, it physically compresses the renal veins, choking off blood flow through the kidneys and immediately stopping urine production. It pushes the diaphragm upward into the chest cavity, making it incredibly difficult for the ventilator to inflate the lungs.
It's squeezing everything.
Everything. It even physically compresses the inferior vena cava, the main vein returning blood to the heart, causing cardiac output to plummet. It is a rapid mechanical death spiral.
So how do you track this pressure before it causes irreversible organ failure? You can't just press on their stomach, right?
No, we use the bladder as a window. The standard of care is routine bladder pressure monitoring.
The bladder.
Yeah, we hook a pressure transducer directly to the patient's urinary catheter. Because the bladder is highly compliant and sits at the bottom of the abdominal cavity, it acts as a perfect fluid-filled balloon that accurately reflects the pressure of the entire compartment.
And if the monitor shows the pressure is too high and the organs are failing,
The definitive management is a decompressive laparotomy.
which means
The surgeons have to make a massive vertical incision from the sternum all the way down to the pelvis, slicing completely through the fascia, and literally leave the abdomen wide open, covered only by a sterile dressing,
just to relieve the pressure.
just to relieve the pressure and allow the organs to breathe.
The sheer physical trauma of saving a life, it's just wild. Okay, we need to take a breath.
Let's do that.
We have spent a lot of time talking about localized pressure in the skull, pressure in the abdomen. We are going to shift our focus now. We are going to look at a microscopic emergency.
Okay.
What happens when the fluid running through all these organs, the blood itself, turns against the bottle?
We are entering the highly complex realm of hematologic and oncologic emergencies in the ICU.
The sources outline a terrifying group of diseases categorized as thrombotic microangiopathies, or TMAs. The two heavy hitters in this category that an ICU doctor must instantly differentiate between are PTP and DIC. Both of these diseases present with two common features: thrombocytopenia, which means extremely low platelets, and microangiopathic hemolytic anemia, or MAHA.
MAHA is a dense medical term, but it describes a very violent physical process.
Yeah, explain MAH for us.
It means that the red blood cells are being physically sheared apart and destroyed as they are forced to squeeze through microscopic blood clots that have formed in the smallest blood vessels, the capillaries.
Like being dragged across cheese graters.
Exactly. When a pathologist looks at a blood smear from these patients under a microscope, they see schistocytes.
Schistous.
Yes. They look like fragmented, jagged, helmet-shaped pieces of shredded red blood cells. The presence of schistocytes tells the physician that the plumbing is clogged with microscopic razor blades.
But the underlying mechanisms causing these clots in TTP and DIC are fundamentally different, and that difference dictates the treatment.
Entirely different.
Let's start with TTP, thrombotic thrombocytopenic purpura. The sources explain that TTP is caused by a severe deficiency of a specific enzyme called ADAMTS13, specifically when the enzyme's activity falls below 10%.
To understand the chaos of TTP, you have to understand the elegant normal function of ADAMTS13. Your body constantly produces a highly adhesive clotting protein called von Willebrand factor, or VWF.
Okay.
When the cells lining your blood vessels first secrete VWF, it comes out as these ultra-large, massive multimer chains. They're incredibly long and incredibly sticky, designed to catch platelets to stop bleeding.
Here's where it gets really interesting to me, trying to visualize this biology. Imagine these ultra-large VWF multimers as microscopic, incredibly sticky strips of double-sided tape unspooling into your bloodstream.
I love that visual.
Normally, this enzyme, ADAMTS13, acts like a pair of biological scissors. It patrols the blood, snipping these massive strips of tape into smaller, manageable, safe pieces that only activate when you actually get a cut.
That is a perfect analogy. The scissors regulate the stickiness.
But in TTP, the patient develops an autoimmune response that destroys the scissors. Their ADAMTS13 activity drops below 10%.
So the tape stays long.
Exactly. Those giant, ultra-large strips of double-sided tape stay huge, and they start unfurling throughout the microscopic blood vessels. They act like nets, catching every single passing platelet, creating massive, sticky traffic jams that completely block blood flow to the brain and the kidneys.
Exactly. And because all of the body's platelets are getting caught in these thousands of microclots, the number of freely circulating platelets plummets. That is the mechanism of the thrombocytopenia.
Right.
But here is the absolutely critical diagnostic pearl that the ICU physician uses to separate TTP from DIC. In TTP, only the platelets are being consumed by this sticky tape.
Okay.
The rest of the blood's coagulation cascade, the highly complex series of proteins and factors that form the fibrin mesh of a normal blood clot, is completely untouched. It isn't broken or activated.
So when you draw blood and run the standard coagulation labs, the PT, the APTT, the fibrinogen levels, they come back totally normal.
Precisely. A normal PT, a normal APTT, normal fibrinogen, combined with terribly low platelets and a blood smear full of schistocytes. That pattern is the hallmark of TTP.
And identifying it means you have to act emergently.
Immediately. The treatment is therapeutic plasma exchange, or PLAX.
How does PLX work?
We hook the patient up to a large dialysis-like machine, remove their plasma, which contains the rogue autoantibodies that are destroying their ADAMTS13, and we infuse fresh donor plasma.
And that donor plasma?
The donor plasma is packed with working ADAMTS13 scissors to immediately start cutting up the clots and freeing the platelets.
That is just brilliant. Now, how does that contrast with the other disease, DIC, disseminated intravascular coagulation?
If TTP is a problem with the sticky tape, DIC is a complete unmitigated meltdown of the entire coagulation factory.
The whole factory.
The whole thing. In DIC, usually triggered by overwhelming sepsis, massive trauma, or obstetric emergencies, the entire coagulation cascade is wildly and inappropriately activated. The body starts forming microscopic fibrin clots everywhere.
So it's consuming the platelets, but it's also burning through everything else.
Yes, it is consuming all the raw materials. It burns through the platelets, the clotting factors, and all of the fibrinogen.
Wow.
Because the raw materials are depleted, the patient simultaneously forms deadly clots in their organs and bleeds uncontrollably from their IV sites.
This means the lab profile is the exact opposite of TTP. In DIC, because all the factors are used up, the PT and APTT are abnormally long and the fibrinogen is extremely low.
Right.
And the sources note you also get an elevated D-dimer, which is just the chemical byproduct of the body frantically trying to break down all those inappropriate clots.
That is the core distinction. TTP leaves the coagulation factors alone. DIC consumes everything.
Let's move to oncologic emergencies, specifically when the treatment for cancer causes a critical crisis. The text highlights tumor lysis syndrome, or TLS.
A very dangerous condition.
This happens when there is a massive rapid death of cancer cells. It is often triggered intentionally by starting highly effective chemotherapy in patients with aggressive, rapidly proliferating cancers like Burkitt's lymphoma, acute lymphoblastic leukemia, or acute myeloid leukemia.
The chemotherapy works exactly as intended, but it works too well.
What happens?
When millions of bulky cancer cells burst open simultaneously,
Yeah.
they undergo rapid cytolysis. They dump their entire intracellular contents directly into the systemic blood circulation.
Just all at once.
Yes, it is overwhelming metabolic insult that the kidneys simply cannot filter fast enough.
The sources list 4 major electrolyte disasters that occur simultaneously. You get massive hyperkalemia, which is too much potassium, massive hyperphosphatemia, too much phosphate, massive hyperuricemia, too much uric acid.
And interestingly, you get hypocalcemia, low calcium.
Let's trace the origin of those electrolytes.
Cells, especially rapidly dividing cancer cells, are essentially little bags of potassium and phosphate. When they burst, the potassium levels in the blood skyrocket, which can cause immediate lethal cardiac arrhythmias.
And the phosphate levels also surge.
Yes.
And the phosphate explains why the calcium drops, right?
Yes, it's basic chemistry. Phosphate has a high affinity for calcium. When all that phosphate hits the blood, it binds extensively to the free-floating ionized calcium.
This just grabs onto it.
Exactly. It creates heavy calcium phosphate complexes that precipitate. They fall out of solution and deposit into the body's tissues. Because the phosphate is hiding the calcium, the free calcium levels in the blood plummet, leading to severe muscle spasms and further arrhythmias.
But the primary danger in TLS, the mechanism that actually destroys the kidneys, is driven by the uric acid, right? Acute kidney injury from uric acid crystallization.
When the cancer cell's DNA breaks down, it metabolizes into uric acid. At high concentrations, uric acid becomes insoluble.
It turns into crystals.
Yes, the uric acid crystals, along with those calcium phosphate complexes, precipitate directly within the delicate microscopic tubules of the kidneys. They physically obstruct the plumbing, causing the kidneys to rapidly shut down.
The pharmacology used to manage this uric acid problem is fascinating. The expert analysis in the sources meticulously contrasts 2 drugs, allopurinol and rasburicase. And this is a vital distinction.
It is a difference between prevention and rescue.
Okay, break that down.
Allopurinol is a xanthine oxidase inhibitor. Its job is to block the enzymatic pathway that creates uric acid. It stops the body from forming new uric acid.
But it doesn't clear what's already there.
Right. It does absolutely nothing to clear or dissolve the massive amounts of uric acid that are already circulating in the blood. Therefore, allopurinol is primarily used for prophylaxis. You give it before you start the chemotherapy.
But if the patient is already in full-blown tumor lysis syndrome and their kidneys are clogging up,
Then allopurinol is too late. You need rasburicase.
what does that do?
Rasburicase is a synthetic recombinant urate oxidase enzyme. It doesn't just stop new production, it actively seeks out the existing dangerous uric acid in the blood and enzymatically converts it into a completely different compound called allantoin.
And allantoin is safer.
Much safer. Allantoin is highly soluble in water, up to 10 times more soluble than uric acid. It doesn't form crystals. It easily dissolves in the blood and is rapidly, harmlessly flushed out by the kidneys and the urine. Rasburicase actively clears the danger.
Wow. There is one more oncologic emergency to touch on. Malignant spinal cord compression. Metastatic lesions, typically spreading from lung, breast, or prostate cancers, grow inside the spinal canal and begin to physically crush the spinal cord.
Yes, patients present with rapidly escalating back pain, progressive weakness or paralysis in their legs, and autonomic dysfunction like losing control of their bladder.
Left untreated, this culminates in irreversible paralysis and neurogenic shock. The definitive treatments are radiation therapy or complex neurosurgery, but those take time to organize.
And time is spine.
Right, so the immediate medical intervention required in the ICU or ER is the rapid administration of high-dose corticosteroids, typically dexamethasone.
That's the go-to.
And the steroids aren't treating the cancer itself, are they?
No, they're treating the collateral damage. A tumor pushing on the spinal cord causes massive local inflammation and peritumoral edema swelling in the tissue immediately surrounding the mass.
And that swelling makes the compression worse.
Significantly worse. High-dose dexamethasone aggressively shrinks that edema, taking some of the pressure off the spinal cord. It buys the neurologist a small, precious window of time to preserve neurological function until the tumor can be definitively removed or radiated.
All right, we have covered the brain, the abdomen, and the blood. Now we are going to look at what happens when our own life-saving interventions become the crisis. We are moving into the world of toxidromes and pharmacology.
The modern ICU uses incredibly potent chemicals to manipulate physiology. Often, a significant portion of our time is spent managing the severe, sometimes lethal, side effects of the drugs we prescribe.
A classic high-yield scenario, the sources outline, is distinguishing between two severe hyperthermic toxidromes, serotonin syndrome and neuroleptic malignant syndrome, or NMS.
They can be tricky to tell apart.
In both cases, a patient comes in burning up with a massive fever and severe confusion. They look identical at first glance. How do you tell them apart?
You have to act like a detective. You look at the timeline of the illness, the specific drugs they have access to, and crucially, the subtle details of their physical neuromuscular exam.
Okay, let's examine serotonin syndrome first.
This is caused by an acute overactivation of serotonin receptors in the central and peripheral nervous systems, specifically the 5-HT1A and 5-HT2A receptors. It is usually triggered by an overdose or an accidental combination of psychiatric medications like SSRIs, SNRIs, or MAOIs.
And the timeline for serotonin syndrome is very fast, right?
Extremely fast. It has a rapid onset, typically developing within minutes to hours of a dose change or a new drug ingestion.
And when you examine their muscles,
The hallmark of serotonin syndrome is hyperexcitability. The neuromuscular system is in absolute overdrive. When you tap their knees, you will see marked hyperreflexia. Their reflexes are incredibly exaggerated.
they jump.
Right. You will also look for a classic finding called clonus, which is a series of involuntary rhythmic muscular contractions and relaxations, particularly prominent in the ankles and lower extremities. You'll also typically see mydriasis, which means their pupils are widely dilated.
The sources say if you need an antidote for this, beyond supportive care, you use a drug called cyproheptadine, which specifically blocks those overactive 5-HT2A receptors.
Yes.
Now, how does that contrast with the other syndrome, NMS?
Neuroleptic malignant syndrome is a totally different pathophysiological beast. It is a rare idiosyncratic reaction to dopamine receptor antagonists, primarily first and second generation antipsychotic medications like haloperidol.
And the onset.
Unlike the rapid explosive onset of serotonin syndrome, NMS is insidious. It develops slowly over days to weeks.
And the muscle exam.
Instead of the hyperexcitability and bouncing clonus, you see profound, severe rigidity. We call it lead pipe rigidity.
Red pipe.
Yes, because their limbs are incredibly stiff and resistant to passive movement in all directions. It feels like bending a lead pipe. And their reflexes, unlike the exaggeration in serotonin syndrome, are either normal or hyperreflexic diminished.
And the antidote for NMS.
To treat NMS, you have to overcome the dopamine blockade. So we use dopamine agonists like bromocriptine or direct-acting muscle relaxants like dantrolene.
Now, I have a fundamental question about the fever here, particularly in serotonin syndrome.
Okay.
If a patient is burning up with a core temperature of, say, 106 degrees, why can't the doctors just push some intravenous Tylenol or ibuprofen to bring the fever down?
It is a logical question, but it highlights a misunderstanding of where the heat is actually coming from.
Oh, really?
Standard antipyretics, like Tylenol, work centrally. They act on the hypothalamus in the brain, which is the body's internal thermostat. When you have the flu, the virus tells the hypothalamus to raise the set point, so Tylenol works by resetting the thermostat back to normal.
But in serotonin syndrome,
The hypothalamus isn't broken. The thermostat is set perfectly to 98.6 degrees.
so why are they 106?
Because the heat is being mechanically generated in the periphery. It is a result of intense, nonstop muscle hyperactivity and clonus. It is thermodynamic friction.
Wow.
Think of it like a car engine redlining in neutral while sitting in a driveway. The engine block gets blazing hot. Turning on the air conditioning inside the cabin, which is what giving Tylenol is like, isn't going to cool the engine down.
You have to shut the engine off.
Exactly. You have to shut the engine off. You have to stop the muscle activity with heavy sedation, benzodiazepines, or even paralytics, and aggressively cool them externally with ice packs or cooling blankets. Tylenol is completely useless because the thermostat isn't the problem.
That is a brilliant way to explain it. And speaking of Tylenol, we have to revisit acetaminophen toxicity. We talked about it earlier when we discussed the liver failure criteria, but the sources go incredibly deep into the cellular mechanics of exactly how it melts the liver and how the antidote works.
It is a fascinating piece of pharmacology. Under normal conditions, when you take a standard therapeutic dose of acetaminophen, your liver processes the vast majority of it through safe metabolic pathways called sulfation and glucuronidation.
Which means?
These pathways package the drug into harmless, water-soluble compounds that you just pee out.
But in an intentional overdose,
In a massive overdose, those primary safe pathways are rapidly overwhelmed and saturated. They hit maximum capacity. The liver has no choice but to force the massive excess of acetaminophen down an alternative secondary pathway, the cytochrome P450 enzyme system.
And that pathway creates the poison.
Exactly. The CYP450 system metabolizes acetaminophen into a highly reactive, highly toxic intermediate compound called NAPQI.
Okay, NAPQI.
Now, usually your liver has a built-in defense mechanism against small amounts of NAPQI. It uses a powerful antioxidant called glutathione. The glutathione rapidly binds to the toxic NAPQI, neutralizes it, and allows it to be excreted safely.
So the liver can handle a little bit of the poison.
Yes, but in a massive overdose, the sheer volume of NAPQI generated by the overwhelmed system rapidly depletes all of the liver's stored glutathione.
The shield drops.
The defense shield is completely exhausted, and once the glutathione runs out, the naked, toxic NAPQI binds directly to the cellular macromolecules and proteins of the liver itself, causing massive central lobular necrosis.
To manage this poisoning, the sources outline the use of a very specific graph called the Rumack-Matthew nomogram. It plots the concentration of acetaminophen in the patient's blood against the time since they swallowed the pills.
A very important tool.
But there is a huge, bolded clinical pearl here. You cannot use the nomogram to make a treatment decision until exactly 4 hours post-ingestion. Why do you have to wait? If they are poisoned, shouldn't you act immediately?
Because treating them based on an inaccurate blood level is dangerous. If you draw the blood 1 hour after they swallow the pills, a large portion of the acetaminophen might still be sitting in their stomach or intestines, completely undigested.
It hasn't reached the bloodstream yet.
Right. You have to wait at least 4 hours to ensure that peak gastrointestinal absorption has occurred. This guarantees that the blood level you are plotting accurately represents the total toxic burden the liver is facing.
And if that 4-hour level plots above the treatment line on the graph?
You immediately administer the antidote, N-acetylcysteine, or NSCC.
And how does NAC save the liver? Does it destroy the NAPQI?
No, it empowers the liver to save itself. NAC literally serves as the chemical precursor to glutathione. You are intravenously handing the liver the exact molecular building blocks it needs to rapidly restock its depleted glutathione defense shield.
Well, that's amazing.
If you give it early enough, the liver synthesizes new glutathione, neutralizes the NAPQI, and averts irreversible cell death entirely.
It's an incredible biological rescue. Okay, before we leave the pharmacology section, we have to touch on what the text calls the transplant tightrope.
Ah, immunosuppression.
Right. We talked about getting a liver transplant earlier. Solid organ transplant patients have to stay on complex, lifelong, multi-drug regimens to prevent their immune systems from rejecting the new organ. But these drugs are incredibly toxic.
They're notoriously difficult to manage. The cornerstone drugs in this field are the calcineurin inhibitors, or CNIs, specifically tacrolimus and cyclosporine.
And how do they work?
They work by inhibiting a specific protein called calcineurin inside T cells. This stops the transcription of interleukin-2, which effectively puts the aggressive T cells of the immune system to sleep so they don't attack the foreign graft.
But the side effects, the sources note that both of these CNIs cause significant nephrotoxicity, they damage the kidneys, and neurotoxicity, which can cause severe hand tremors or a brain swelling condition called PRES.
Yes, they are tough on the body.
But where they differ and what doctors have to choose between are their unique, bizarre metabolic side effects. Let's start with tacrolimus.
Tacrolimus is highly diabetogenic. It is notoriously toxic to the beta cells of the pancreas, the cells that make insulin.
So it causes diabetes?
Yes. By damaging these cells, it frequently causes new-onset diabetes after transplantation or NODAT. Patients who never had blood sugar issues suddenly require insulin. It is also heavily associated with alopecia, or significant hair loss.
So you get a new organ, but you might get diabetes and lose your hair. Now, what about cyclosporine?
Cyclosporine avoids the severe diabetes risk, but it causes a condition called gingival hyperplasia. The drug stimulates the fibroblasts in the gums, causing the gum tissue to grow uncontrollably, sometimes completely covering the teeth.
Wow, that sounds awful.
It is. It also causes severe hirsutism, which is excessive abnormal hair growth all over the body, and profound hyperlipidemia, sending cholesterol levels skyrocketing.
So the physician and the patient are essentially forced to trade diabetes and hair loss for overgrown gums, excessive hair growth, and high cholesterol, all while trying to protect the kidneys.
It is a brutal, constant physiological trade-off.
And what about the other classes of immunosuppressants? The sources mention mTOR inhibitors, like sirolimus.
Sirolimus avoids the severe kidney damage associated with the CNIs, which makes it attractive. but it works by inhibiting the mTOR pathway, which is critical for cellular division and proliferation.
Okay, so if it stops cells from dividing.
It causes profound bone marrow suppression, leading to dangerously low white blood cells, red blood cells, and platelets. Crucially, because it stops cellular proliferation, it drastically impairs wound healing.
Which is terrifying for a patient who just had a massive transplant surgery.
Exactly. It frequently leads to postoperative wound dehiscence, where the surgical incisions simply fail to heal and break wide open.
Oh, that's a nightmare. And finally, the antimetabolites like mycophenolate.
Mycophenolate targets lymphocyte proliferation. But its limiting factor isn't usually the kidneys or the wounds, it is the gut. It causes severe dose-limiting gastrointestinal distress, presenting as intractable watery diarrhea that can dehydrate a patient and be incredibly difficult to medically manage.
So, synthesizing all of this, what does this mean for the critical care physician standing at the bedside? We have talked about managing the pressure inside a failing brain, tracking the inflammatory floodwaters of a dead pancreas, analyzing microscopic blood traffic jams, and balancing incredibly toxic transplant drugs.
It's a lot.
How does one human being process all of this data simultaneously? This brings us to our final section: bedside tech, scoring, and the final frontier of ethics.
The sheer volume of data generated by a critically ill patient is overwhelming. To manage this complexity, to make sense of the chaos, modern critical care relies heavily on scoring systems to quantify illness and bedside imaging to visualize it.
The sources contrast two major scoring systems used in the ICU, Apache and SOFA. And the difference between them isn't just mathematical, it is philosophical.
That is exactly right. Let's look at Apache first. Apache evaluates the risk of mortality based on the worst physiological variables recorded during the first 24 hours of a patient's admission to the ICU.
Right. It takes their worst blood pressure, their worst oxygen level, their worst lab values, and calculates a percentage risk of death.
But it is only looking at that first 24 hours.
Right. It's a snapshot.
Exactly. It's a singular static prediction of whether this patient will survive the hospital stay based solely on how terrible they looked when they first crashed through the door. It is useful for research and baseline severity, but it doesn't help you manage them on day 5.
And that is where SOFA comes in.
SOFA stands for the Sequential Organ Failure Assessment. And as the name implies, it is explicitly designed to be dynamic. It longitudinally tracks 6 specific organ systems: respiratory, coagulatory, hepatic, cardiovascular, neurological, and renal. You recalculate the SOFA score every single day.
So instead of a snapshot, SOFA is a movie.
Yes. It shows you the clinical trajectory. It answers the most important question in the ICU. Is what we are doing working? Is the patient trending better, or are they sliding deeper into multi-organ failure? It allows the physician to track the momentum of the disease.
And alongside these numerical scores, we have a major focus on immediate visual data through POCUS point-of-care ultrasound. This isn't sending the patient down to the radiology department.
No, this is the doctor wheeling a small ultrasound machine right up to the bed to look inside the body in real time.
POCUS has completely revolutionized critical care, especially when it comes to pulmonary ultrasound looking at the lungs.
It's a game changer.
The document breaks down the specific artifacts you look for in the lungs because ultrasound waves don't travel through air very well. Normal, fully aerated, healthy lungs basically act like a mirror. They completely reflect the ultrasound waves back to the probe.
Yes.
This reflection creates repetitive horizontal reverberation artifacts on the screen called A-lines. A-lines mean the lung is full of air.
But if you think back to our discussion on pancreatitis or burn patients, what happens when the lungs fill with fluid?
Acute respiratory distress syndrome, pulmonary edema.
Exactly. When the microscopic interstitial space between the air sacs, the alveoli, becomes thickened and heavy with inflammatory fluid, the physical properties of the lung change.
How does the ultrasound see that?
The ultrasound waves interact with that fluid-thickened tissue differently. Instead of horizontal reflections, they create vertical, ray-like, bright, hyperechoic artifacts that shoot down from the surface of the lung all the way to the bottom of the screen. We call these B-lines.
And the text notes that these B-lines actually move back and forth in time with the patient's breathing, and they are so bright that they literally obliterate and erase the horizontal A-lines.
The diagnostic rule is that if you see 3 or more B-lines in a single ultrasound view, you have alveolar interstitial syndrome. The lungs are wet.
It is a highly specific, immediate bedside marker for extravascular lung water. You don't have to wait for an X-ray to know the patient is drowning in their own fluids.
It's immediate data.
And then there's a specific ultrasound technique called M mode or motion mode, specifically used for rapidly diagnosing a pneumothorax, a collapsed lung. I want to explain the physics of this because the visual analogy is incredible.
Go for it.
On M mode, the machine tracks movement over time across a single line. If the lung is healthy, it slides back and forth smoothly against the inside of the chest wall as you breathe.
Right.
On the screen, the sliding creates something called the seashore sign. The stationary tissue of the chest wall at the top of the screen looks like straight horizontal waves, the sea. And the moving, sliding lung tissue below it creates a grainy, speckled pattern, the sandy beach.
It proves the lung is inflated and moving perfectly against the wall.
But if a patient has a pneumothorax, a pocket of air gets trapped between the chest wall and the lung, collapsing the lung inward. The ultrasound waves cannot see through that trapped pocket of air, so the machine can no longer see the lung moving underneath. The sliding is completely abolished.
And how does that change the image?
The M mode image changes from a seashore to a barcode. They call it the stratosphere sign. Because there is no movement being detected, the entire screen, from top to bottom, just becomes continuous, perfectly straight horizontal lines. It looks exactly like scanning a barcode at a grocery store checkout. It is a flat, static, lifeless scan.
It is a pathognomonic finding.
Mhm.
If you see the barcode sign in a crashing patient, you know instantly you have a collapsed lung, and you can immediately intervene with a chest tube to save their life.
Which brings us to the final and perhaps most profound part of this entire document. We have spent this time marveling at the technology. We have complex ultrasound physics, intricate pharmacological algorithms, and massive life support machines.
The very limits of medical science.
But eventually in the ICU, the medicine always meets the absolute limits of the human condition, and we enter the realm of bioethics.
The most challenging terrain in the intensive care unit is rarely physiological. It is almost always ethical. Yes. The math and the science can only take you so far. And these dilemmas frequently center around the foundational concept of informed consent.
Informed consent is the bedrock of all modern medicine. A doctor has to explain the risks, the benefits, and the alternatives to a patient before they touch them, and the patient has to agree.
Under normal circumstances, yes.
But in the ICU, that paradigm falls apart. The patients are often unconscious, incapacitated, heavily sedated, and crashing fast.
The American Medical Association Code of Medical Ethics, specifically relying on principles outlined in Opinion 2.1.1, provides explicit guidance for this exact nightmare scenario.
What's the guidance?
When a medical decision must be made urgently to preserve a life, and the patient completely lacks the capacity to consent, and no legal surrogate or family member can be reached in time, doctors are ethically and legally justified to operate on an emergency exception.
And this relies on a deeply philosophical concept called presumed consent.
Yes. It is the rational, foundational assumption that a reasonable human being would want to be saved. We presume, ethically, that they would consent to life-saving therapy intubation, central lines, massive transfusions under dire circumstances.
But you don't need a signature to save a life.
It legally allows the physician to act immediately to stop the dying process. Of course, the mandate is that once the patient is stabilized, or a family member finally arrives, the ethical obligation immediately shifts back to obtaining formal, ongoing consent for continued treatment.
But what happens when the algorithms, the drugs, and the presumed consent aren't enough? What happens when the intracranial pressure we talked about in the very beginning of this journey rises higher than the blood pressure and the brain completely starves of oxygen? The sources end with the heavy clinical reality of determining brain death.
Brain death is formally defined as the irreversible cessation of all functions of the entire brain, including the brainstem. It is usually caused by the massive global cerebral anoxia and herniation we discussed earlier.
But the ethical and legal nuance here is massive and often deeply misunderstood by the public.
It is. The document emphasizes heavily that brain death is a clinical diagnosis of death. It is not an elective medical procedure.
That's a crucial distinction.
While there are some specific state-by-state legal variances and accommodations for religious objections, the broad consensus guidelines state that doctors do not technically, legally require surrogate or family consent to perform the final confirmatory test, like the apnea test.
Right.
They are diagnosing a state of death that has already occurred. They are not asking permission to withdraw treatment from a living person.
The legal framework is rigid, but the clinical reality of standing in that room with a grieving family who is looking at a loved one whose chest is still rising and falling because of a ventilator.
Exactly. The human element completely overrides the rigid legal framework at the bedside. A physician cannot simply point to a legal statute and walk away.
Yeah.
Clinicians must navigate this diagnosis with extreme empathy, robust communication, and profound patience. You may not need legal consent to declare the death, but you absolutely need profound compassion and time to guide a family through understanding that the person they love is gone, despite what the machines make it look like.
Wow. Let's take a step back and recap this incredible journey. We started with the physical physics of the brain, exploring the Monroe-Kelly doctrine and how doctors manipulate gravity, salt water, and carbon dioxide to manage extreme pressure inside a rigid skull.
We covered a lot.
We moved down to the systemic collapse of the chemical factories, tracking the inflammatory hurricane of a dying pancreas and the massive fluid shifts of severe burns. We zoomed into the bloodstream, differentiating between the microscopic sticky tape traffic jams of TTP and the total coagulation meltdown of DIC.
We really went everywhere.
We tracked the toxic limits of life-saving drugs, understanding why Tylenol doesn't cure a serotonin fever and how it melts the liver, and we ended with the visual data of ultrasound barcodes and the profound ethical weight of bedside decision-making.
It requires a staggering breadth of knowledge to operate effectively in that environment. It demands an understanding of physics, chemistry, anatomy, and human psychology, all applied under extreme time pressure.
It does. And looking at all these sources leaves me with one final, incredibly provocative thought about the intensive care unit. For an hour, we have talked about the most mathematically rigorous, technologically advanced, and scientifically demanding environment in all of modern medicine.
The pinnacle of medical tech.
We have algorithms for everything. We measure physical pressures down to the exact millimeter of mercury. We track enzymes and electrolytes to the decimal point.
We rely entirely on the data.
Yet, at the absolute climax of all this technology, when a patient's life literally hangs by a thread, when time has run out, the family is missing, and the patient is crashing, the entire sophisticated, multi-billion-dollar medical system defaults back to a deeply, anciently human philosophical concept, presumed consent.
It is a powerful realization.
The ultimate safety net of critical care isn't a mechanical ventilator or an ultrasound machine or a perfectly timed antidote. It is the fundamental ethical belief in our shared human will to live and the profound empathy required to act on it without asking. The X-ray machine might be broken, the diagnostic waters might be murky, but the drive to save a life cuts right through the chaos. It makes you ponder just how perfectly technology and human philosophy have to intertwine right there at the very edge of life and death.